Management of enterocutaneous fistula, ECF. An enterocutaneous fistula, ECF, is an abnormal communication between the gastrointestinal GI tract and the skin, often resulting from surgery, trauma, or underlying conditions like Crohn's disease. Effective management requires a multidisciplinary approach involving medical, nutritional, and sometimes surgical interventions. Initial assessment and classification. Management begins with thorough evaluation. 1. Etiology. Determine if the ECF is due to surgery, inflammatory bowel disease, malignancy, or trauma. 2. Location and output. Classify based on fistula output. Low output, 200 milliliters per day. Moderate output, 200 to 500 milliliters per day. High output, 500 milliliters per day. 3. Presence of sepsis or abscess. Identify signs of infection using imaging, CT or ultrasound, and clinical examination. 4. Malnutrition. Assess nutritional status, as ECF is associated with significant fluid, electrolyte, and protein loss. Medical management. The initial phase focuses on controlling sepsis, optimizing nutrition, and protecting the skin. 1. Sepsis control. Treat with broad-spectrum antibiotics, especially in the presence of abscesses or peritonitis. Perform percutaneous or surgical drainage of intra-abdominal collections. 2. Fluid and electrolyte management. Replace fluid losses to prevent dehydration and correct electrolyte imbalances like hyponatremia, hypokalemia, or acidosis. 3. Nutritional support. Nutritional optimization is crucial as malnutrition is common and adversely affects outcomes. Total parenteral nutrition, TPN, is preferred initially to bypass the GI tract and allow the fistula site to heal. Enteral nutrition, EN, may be introduced if the fistula is low output and located distal to the feeding site. 4. Skin care and wound management. Prevent skin breakdown from effluent using ostomy appliances, wound dressings, and barrier creams. Negative pressure wound therapy, NPWT, may help manage fistula effluent and improve local healing. Definitive management. Definitive management depends on the fistula's output, healing potential, and underlying cause. 1. Conservative therapy. Spontaneous closure occurs in up to 70% of low-output fistulas, especially when the distal GI tract is intact and there is no distal obstruction or infection. Maintain supportive care for 4 to 6 weeks to allow time for healing. 2. Surgical intervention. Indicated if conservative measures fail, the fistula persists beyond 6 months or complications arise, e.g. obstruction, ischemia. Surgery involves resection of the fistula tract, correction of underlying pathology, and restoration of GI continuity. Adequate preoperative optimization, including improving nutritional status and resolving infections, is critical. Complications and long-term management. 1. Complications. Persistent infection, electrolyte imbalances, malnutrition, or fistula recurrence. Ensure close monitoring for signs of sepsis and progressive malnutrition. 2. Rehabilitation. Patients may require long-term nutritional support and psychological counseling. Address underlying conditions like Crohn's disease or malignancies to prevent recurrence. Conclusion. Effective management of enterocutaneous fistulas requires a patient-specific, multidisciplinary approach focused on sepsis control, nutritional support, and protection of the skin. While many fistulas may close spontaneously with conservative management, surgery may be necessary in refractory cases. Early intervention, vigilant monitoring, and a focus on underlying etiologies significantly improve outcomes.